So in the image you see here, this shows a normal FDG scan on the left and a patient with Alzheimer's disease on the right. FDG just looks at glucose metabolism of the brain, and so it can be used for a variety of different disorders and is still used for Alzheimer's and dementia imaging, even though we do have other agents like amyloid and tau. FDG is the most widely available PET tracer for body and brain imaging. It localizes to areas of increased glucose metabolism seen in high physiologic activity. In the brain, glucose is already the predominant substrate for metabolism, so there is intense tracer uptake in the normal cortex and basal ganglia, and malignant brain tumors will show increased glucose metabolism. Primary brain tumors often do not, so FDG neuro-oncology can be tough to distinguish inflammation from tumor, and it can be tough anyway because the brain is already going to be really hot because there's a lot of glucose uptake, and so sometimes it can be difficult to see areas of increased uptake or specify between increased metabolic activity and things like inflammation. So FDG uptake seen on FDG PET and PET CT imaging is what we're looking for. So the rationale for the test is that it is a diagnostic tool to evaluate the brain's glucose metabolism and function. Since a lot of things do that, we can image a lot of things with FDG. The brain will always show up really, really hot on FDG studies because your brain actually uses about 20% of the glucose that's available. The FDG test will accurately assess changes in metabolic activity, and it may explain irregularities in mental or physical status. Of course, not just different diseases, but also neurologic and mental health conditions can alter that glucose metabolism or the metabolic activity of the brain. Some other benefits, looking at epileptic seizures, grading tumors, directing biopsies, evaluating malignancy, and something that is seen on other imaging, differentiating between radiation necrosis and tumor, and differentiating toxoplasmosis from CNS lymphoma. Talk about the cancer stuff a little later on. Also, though, it's really good for looking at infections in the brain and looking at how that's changing the glucose metabolism. And then at the very end of this lecture, we will talk about how FDG brain scans are being used in criminal cases as well. There are a lot of indications for doing FDG brain imaging. If somebody has behavioral changes like depression, difficulty with speech or swallowing, involuntary muscle activity, general confusion, any kind of cognitive decline, or mild or severe cognitive impairment, especially if there was a sudden onset. And then if they have a seizure disorder and they want to locate the location of the seizures, those are all kind of behavioral indications for doing an FDG brain study. They can also be done to rule out certain diseases, help get a differential diagnosis on things like dementia, evaluate tumors to see if they're primary or metastatic and where they're located, how metabolically active they are, and then also assessing things like traumatic brain injury. There are a couple contraindications for doing FDG brain scans. Of course, pregnancy and breastfeeding are not absolute contraindications, they are relative ones. And so that means if they can still be done on someone who is pregnant or breastfeeding if there is a medical necessity and if the benefits outweigh the risk. Patient must be properly informed and sign a waiver. And then, of course, always follow the imaging facility's radiation safety guidelines and make sure that the patient is educated, signs of release, and that they have been given proper written instructions and that they actually understand them and agree to follow them. Now, if somebody's glucose is really high, you can't do the test. This blood glucose level is going to vary a little bit per facility. And typically, if it's greater than 200, you will want to reschedule the scan. For brain scans, there's a little bit lower threshold than oncologic studies. So for most brain scans, if it's between 150 and 200, their doctor might want to consider rescheduling it or trying to bring their glucose down a little bit. And if it's higher than 200, they will reschedule the scan. The reason for that is because if you have a high blood sugar, then the cells in your body are already saturated with sugar. They have an overabundance in your bloodstream. They're not going to take up any more glucose because they're fat and happy on everything that's already in your bloodstream. Well, what's in your bloodstream is not radioactive, so we can't see it. So when you give somebody the FDG and their blood sugar is really high, it'll kind of circulate, it'll get forced into their soft tissue, which is the last place glucose goes, and it just won't uptake. So that's something that is really important to consider. You always want to make sure you check their glucose before you start, because otherwise it just won't go to you actually won't see your brain very well. Patients' inability to lie still for 30 to 60 minutes has to be taken into consideration. You can give sedation if needed. Of course, follow your department protocols and policies. You as the tech may not be able to some places, but that just is going to allow the patient to relax a little bit. You would want to give it about 20 minutes or so before you start imaging them so that it has time to kick in. This is really not a common practice. Most of the time, patients are going to be able to just lay down and lay still, or you can work with them with guides and things like that to help remind them to hold still. And so it would be very, very rare occasion that you would need to sedate a patient for this test. So that's really important that the patient or caregiver be educated and given written instructions. There's a diet that needs to be followed, plus the blood sugar, plus the prep of a quiet, dim lit room. So there's a lot of moving parts to an FDG study that really have to be followed because if they're not, it will impact the glucose metabolism. Patients should be NPO for at least 4 to 6 hours. They can have water, but nothing else. And then you want to hold any fluids containing dextrose or feeding if they are an inpatient for 4 to 6 hours. They need to be fasting during that time. And then right before injection, you want to check their blood sugar. If it's over 200, you will need to reschedule. And then they also need to discontinue anything that could affect their glucose metabolism for at least 24 hours prior to the test. So that includes caffeine, alcohol, any other drugs. Some things are over the counter, some prescription or illegal medications. And then just avoid anything that's going to impact their glucose uptake. When you're obtaining a medical history for somebody with an FDG study, you want to get a very accurate, detailed list of all their medications, any recent surgeries that they may have had, and a really good history, whether or not they have diabetes, if they've ever had any head trauma, memory impairment, stroke. Transient ischemic attacks are also kind of known as a mini stroke. So a lot of older people would call it that. And then epilepsy, if they've ever had seizures or seizure disorder, they've ever had any vitamin or metabolic deficiencies, and anything that would affect their brain at all or cause trauma, bruising, bleeding, anything like that within the brain. And then results of any neurologic, psychiatric, or mental status test, because patients who have certain psychiatric disorders or their mental status is compromised, like they have like depression or something like that, even anxiety, that can show up on the FDG test as well. And then if they've had any other brain imaging studies, it's always important to ask that CT, MRI, or SPECT. And then PET is on that list also because some patients do get multiple PET scans. For example, patients with dementia might get amyloid, tau, and FDG before or during their treatment. And patients with brain tumors might get multiple different types of studies as well. For the acquisition, you want to confirm that the patient followed their prep and other instructions, obtain IV access, and monitor the flow. In a dimly lit room, you will have the patient sit or recline for about 20 to 30 minutes before you inject them. Now, it's best practice to put them in the dimly lit room and start their IV, you want to start it where you can see. So whether you start the IV and then put them in the room or put them in the room and then close, turn the lights off, doesn't really matter. But you want to start their IV first because that gives them time to quiet down and relax for that 30 minutes before you inject them. If people are stressed out about their IV or you have the lights on, you're talking to them, they're experiencing pain, that can all affect their glucose metabolism. So get the IV out of the way and the finger stick for their glucose, and then put them in a quiet, dimly lit room. They can sit or recline for about 20 to 30 minutes. And then you want to explain the test really well to them before you put them in that room and let them have that resting time because when you come back to inject them, you don't really want to talk to them. They're not allowed to really talk that much or read because that can affect the areas of the brain that get glucose. You want them to remain quiet. Always inform the physician if the patient was unable to lay still or didn't follow that prep during the pre and post injection uptake. Patient will void prior to imaging and then put them on the table with their arms down to their side. You can use a head holder if you want. It is best practice because it will kind of hold their head in place so they can't move. You don't really want to use a foam headrest, and there are specific head holders that come with camera manufacturers, and you can use those. You can also lightly put like a Velcro strap or something around the patient's head, very loosely, but just kind of to remind them to hold still for the images. And you want to monitor the patient for movement and things like that during the scan, but you don't really want to interact with them a whole lot during their uptake phase. So injection to scan time is also going to vary slightly by facility protocol, but it's going to be about 30 to 60 minutes. You need that to get taken up by the brain. It'll get taken up by the brain fairly quickly because your brain metabolizes glucose. And like I said earlier, it uses 20% of what's available to your body. And so your brain's using a lot of it. It's going to get taken up by there. Peak kind of uptake time is around 60 minutes for FDG. That's when you'll see the best uptake in all the tissues of the body. That's the minimal background, so you get the best target to non-target ratio or signal ratio, but then you also don't have a lot of washout yet into the urinary system. So that's your sweet spot is 60 minutes. Energy peak is always a wide energy peak with PET. but you'll have it to be at about 250 to 600 keV. You can scan them in 2D or 3D. Remember, when you're doing 3D, it's a lot more sensitive. You get a lot higher count rate. When you're doing 2D, it's going to take a lot longer because you don't have as many counts. You can typically scan them in one bed position for the brain. If you're doing 2D, it's going to take 20 minutes. If you're doing 3D, it's going to take 6. And make sure that you have the entire brain in the field of view. You want to include the cerebellum as much as you can. And then afterwards, you'll do attenuation correction. If it's standalone PET, you can do that with cesium or germanium source. But if you are doing PET CT, which is the most common, then you would use the CT acquisition. And this is just a kind of visual aid to show you the process. So patient will come and rest for 20 to 30 minutes in that dimly lit room in the quiet. Patient cannot read, watch TV. They cannot have their phone on during that time. They've got to just sit there. You want them to try to stay awake, but you also want them to just kind of sit there and relax, because if patients fall asleep and they dream, that can also impact their metabolism of the glucose when you go to inject them. Inject the patient with about 10 to 20 millicuries of FDG, and then let them sit for another 30 minutes to 60 minutes in that same quiet, dimly lit room. Still not allowed to do anything. We don't want them falling asleep. No noise, no TV, no reading, no talking, no playing on their phone. At this point, when they're in the uptake room and you need them to be quiet, they should not have any family members with them either, because the family members always end up talking to each other. And then sedation if necessary, 20 minutes for 2D scanning and 6 minutes for 3D. When you process the images, you'll have transaxial slice thickness of about 2 to 4 millimeters. You'll use filtered back projection. Remember, all PET initially uses filtered back projection. That's how it creates the lines of response. But then when you actually reconstruct the images and fuse them with CT, you use iterative reconstruction, because the CT provides that patient map for us. And then there's always manufacturer recommendations for how many iterations to do, the final smoothness, things like that comes from the manufacturer's recommendations. The brain will be displayed in transverse coronal and sagittal planes, and then processing techniques will vary slightly by equipment as well. So this is a normal study. You will see that there is regional cerebral metabolism. You'll see that there is a lot of gray matter, not a lot of white matter, and you want to look for symmetry. So this is just kind of showing you that their normal aging will have some cortical atrophy, and that's normal as patients age. So as you're doing patients that are older for any FDG studies, just know that they may, have some atrophy that shows up, and that's normal. So with FDG, like I said, you want to look for symmetry. You'll have more uptake in the cortical region, or the gray matter that outlines the brain. Mildly decreased mid-temporal lobe activity. That is normal as well. I'm kind of pointing my laser pointer at it. You see it right there. And it should still be fairly symmetrical. It's really important that you have their head straight when you're looking for symmetry. Otherwise, you're looking at two different areas of the brain and trying to make them symmetric. And so it's very important for some symmetry that the patient is positioned properly. And then it's also normal to see some hot spots in the posterior cingulate cortex. You will also see more gray than white, especially in the frontal, parietal, occipital lobes and the basal ganglia. Basal ganglia is right here, kind of in the middle. You see the striata there. And then it's normal for the cerebellum to be a little bit lower activity because you have more white matter. This is an example of an abnormal study. This one is actually Huntington's disease. We can also image Huntington's with F-DOPA, so we will talk about that in a future lecture. But this is showing hypometabolism. Huntington's disease is a neurodegenerative disease. It's progressive disease with no cure. And so the arrows there are pointing to areas that are hypometabolized or have decreased uptake. So FDG can be used to assess the pathophysiology of a stroke, and it's used in many contexts. It's not good for an acute stroke, but it can be used for it. It's more often used at looking at regional blood flow, seeing if perfusion has been restored, and seeing any changes in metabolic activity. And if there's any areas of ischemia or necrosis or death, that will show up. But PET's ability to measure inflammation allows for really good measurement of arteriosclerosis, plaque vulnerability, things like that within the blood vessels of the brain. And it's also widely been used to look at ischemic insults, which is like the effects of ischemia. But post-stroke recovery is a very complex process. Your brain naturally has inflammation there, and that inflammation is part of your immune system to help your body heal. But you have scar tissue forming, you have fibrogens going there, fibroblasts, all those immune cells and cells that help to recover and create scar tissue. All those cells are rushing to the area. You have inflammation, and then you also have the possibility of further bleeds, and then you also have some cell death that's occurring. And so all around normal metabolism. And so it's very complex, and there's a lot of things that can alter the FDG uptake in that process. And so that's where good history and things like that come into play, knowing what kind of stroke the person had, where, the extent of it, when it happened, all of that stuff is important. So, like I said, there's pitfalls. One of them is a lack of standardized protocol, knowing exactly when in the stroke process the FDG is best and how to image them. Another is the long uptake time for FDG. It's not good for an acute stroke. And I mean, think about it. They have CTs with stroke protocols that the patient can be done in 5 to 10 minutes. But with FDG, the patient who's suspected as having an acute stroke would have to sit for 30 minutes in a quiet, dimly lit room, then be injected, then sit for another 60, and then be scanned for 20 if you're doing 2D imaging. That's over 2 hours that patient with a suspected acute stroke has been getting their FDG scan. It's really just not practical, especially when you could do an MRI much quicker, or you could do a CT in about 5 to 10 minutes. So that's something that has always held FDG back with stroke imaging. There's also transient glucose metabolism changes after stroke. There's transient hyperglycemia, which means that an area will just be hyperperfused and then it won't for a while. That makes it really hard. You got to image them at the right time, and you don't know when the right time is. You're just guessing. So you might catch it, you might not. And then there's peri-infarct spreading of neuroinflammation. Peri-infarct just means around the infarction, around where those cells died. And those can produce false results as well. So a big pitfall for FDG is that the area of the stroke will have decreased perfusion and metabolism, but then there are also transient hyperglycemia where it might take up more all of a sudden. And then also localized inflammation will increase uptake in that area. So all of those things kind of work together to make it really difficult to get a good, accurate diagnosis with FDG for strokes. You will talk about SPECT imaging with technetium agents, and those end up being a lot better for stroke imaging. And now we have epilepsy imaging. This is another one that can also be done with SPECT, but it has been replaced with PET where PET is available, just because you get a little bit better imaging quality with the PET. And one of the problems, though, is still the prep, the quiet, dimly lit room, all of that stuff. So the image that you're looking at is an interictal and ictal PET. Ictal means at the time of their seizure, and interictal means the resting phase, kind of when they're between seizures. So interictal means they're just kind of normal hanging out, but ictal means they're actively having a seizure. What you see in these images is that at their baseline, when they're not having a seizure, there is an area of the brain that is hypoperfused, which means or not really hypoperfused, but hypometabolic, which means it's not really metabolizing glucose. It's a low uptake in that area. But then during the seizure, that area becomes very hypermetabolic and is using up a lot more glucose than the rest of the brain. So that's something that's pretty common with seizure disorders. That'll be hypometabolic at rest, but during the actual seizure, it will be hypermetabolic. So it will show up as hot. Ictal imaging or epileptic imaging is often done as a pre-surgical evaluation, and this looks at the pharmacoresistant epilepsy, so it's people who drugs aren't working for them, they're still having seizures, and it's done to identify the area of the brain that the seizure is coming from so that doctors can operate on that specific area of the brain. It has much higher sensitivity than SPECT, especially in the temporal lobe. It goes up to about 80-something% of seizure foci that it will find. And SPECT is only in the 60s. So it's much more sensitive to actually finding the disease. It's not as great for extra temporal lobe epilepsy, which is epileptic seizures that happen outside of the temporal lobe. It just the sensitivity and specificity goes way down for that. It is best paired with MRI or PET-MR if you can, or correlating it later with the MRI studies. And remember, ictal phase means it's during the seizure, and interictal phase means it's during rest. And so this is the same picture again because I just wanted to revisit that and show you that in this specific patient, notice the interictal, the baseline, it's hypometabolized, and then in the ictal phase, it's hyper. So image A is really just a classic representation of the interictal, and then this is pretty typical of what an ictal scan would look like and how that's used then for surgical planning because the doctors can see what area of the brain is causing the seizure. It won't always be that specific area of the brain. It could be kind of anywhere. A lot of times you'll see it in the temporal lobes like that. Like I said, it's much better when it's temporal lobe epilepsy. When it's like parietal, frontal lobe, things like that, PET is not near as sensitive or specific, and it gets a little bit harder to localize where it's coming from. So this one is another one, and this shows you it's a little bit higher, more to the side, closer to your parietal lobes. But you see it kind of spans that area there. This case I wanted to show you because it demonstrates the close correlation with MRI and how beneficial they can be. This particular one is using something called a subtraction method, and sometimes techs do it. A lot of times physicians can do it on their software if they feel like they need it to kind of help them read the test. But it's just combining the ictal and interictal phases. It kind of overlaps them on top of each other, and then it will subtract everything out so that what's left is only the areas that are hypermetabolized. And then that information is overlaid onto the MRI so that you can see the exact areas of the brain that are hypermetabolizing. And MRI gives just such amazing detail in the brain. You see the differences in white and gray matter. You see all the sulca and the gyri, and you can kind of differentiate some of the different anatomy. Can't really do that with anything else. MRI is just really good for looking at that structure. And so for pre-surgical planning, to be able to overlap the ictal scan data from the PET with the anatomical information from the MRI is extremely beneficial for surgeons because they can see exactly which little fold of the brain they need to go in and operate on. So fantastic for that. Dementia and movement disorders are discussed separately, but for decades, FDG was the only FDA-approved radiopharmaceutical for dementia imaging. It is still recommended for assessing atrophy and areas of hypometabolism, and it's used in conjunction with other neurodegenerative and dementia imaging radiopharmaceuticals. So it is still used in conjunction with amyloid and tau to fully assess the atrophy in any areas of hypometabolism. And this is a case example of a 56-year-old woman who presented with early onset dementia without a family history of Alzheimer's disease. The FDG PET images show bilateral posterior parietal, posterior cingulum, and temporal hypometabolism. So you can see it with using the white arrows. So this one up here is the temporal hypometabolism. Down here with this one, we have the posterior parietal lobe that has hypometabolism. And then you also see the posterior cingulate that has hypometabolism as well. So this uptake pattern is suggestive of Alzheimer's disease with frontal involvement. And remember that FDG is, for decades, was the only radiopharmaceutical approved for PET brain imaging. And so it is still used with neuro-oncology. And one thing that I want to note here is that it's really good at looking at metastatic tumors because those will hypermetabolize glucose. It is not as good at looking at primary brain tumors because they typically do not hypermetabolize glucose. They also have a lot of neuroinflammation around them and necrosis inside of them, and so it just becomes a very messy tumor to look at where you have areas of hypo and hyperperfusion all messed up in one messy mass. But when we're talking about metastatic tumors of the brain, FDG is really good for that. Those tend to be a little bit more focal. You do have some inflammation around them. Anytime there's a space occupying lesion, it also causes some inflammation locally, but they are typically a little bit more confined, and they have hypermetabolism. And so this is an example here in these images of a patient who had melanoma of the toe. Melanoma is known for spreading to the brain. Typically with FDG scans for melanoma, we scan from vertex to toes because it has a high likelihood of metastasizing to weird areas, especially the brain. In this example, there's focal increased FDG uptake in the midline anterior to the third ventricle where that arrow is pointing. And image A is the PET by itself, and image B is the PET-CT fused images. So this is a patient with cerebral metastases. And then lastly, this is an example of primary brain tumors. FDG typically is not good for that. Most of the primary brain tumors do not hypermetabolize glucose. They are typically pretty aggressive, especially when it comes to gliomas. There are some less aggressive primary brain tumors that are more slower growing. But regardless, none of them really metabolize glucose at a faster rate than normal cells. They tend to metabolize amino acids, or they overexpress somatostatin receptors, things like that, but they do not take up glucose at a faster rate. Now, when it comes to gliomas, those are very messy tumors. You'll have areas of necrosis inside of them that will be cold, surrounded by regular activity where it's not taking up glucose at a higher rate, and then you have inflammation around it, which causes hypermetabolism or increased glucose uptake. And so it's not uncommon for primary brain tumors to just be a little messy when it comes to the FDG uptake. You'll have areas of hyper and hypoperfusion, and you may see areas of inflammation around it. It makes it difficult to actually see the tumor or assess the full tumor burden. And so there are other imaging agents that are coming out to be a little bit more specific for primary brain tumors. And that's it for FDG for brain imaging. Thank you for watching this review.